just the timeline, there's 6 points or 5 points on the timeline, or really 4 points, and then an update for what's going on right now. And in 95, up to 95, Medicaid in Connecticut was fee for service with very little management or oversight. And so prices, the cost went sky high and so forth. And so the state decided to go to a capitated managed care model. And unfortunately, as we'll see, this didn't work very well. That led us to a coalition of health advocates, which I'll call the HAC for the rest of the presentation, filing a lawsuit against one of the MCOs, as well as the State Department of Public Health. Next step was 2010, when Daniel Malloy was elected governor, and we got rid of the capitated managed care and went to the ASO model, and which actually was implemented in 2012. And it's worked very well for the last 17 years, but now it's under threat, and I'll talk a little bit about that. So, so I've already mentioned this. Aside from the costs, the patients were getting very poor care, no coordination of care between different specialists, very difficult finding care in the first place, and I'll give you some more details about that. But you may remember back in the mid-90s when managed care was going to solve everything, and the new Wall Street miracle approach to healthcare. And as we all know, it hasn't worked out so well. It's worked out well for them, but not so much for us. So when they first put this in place, the plan was to save money by giving the MCOs 95 cents on the dollar, based on a benchmark of how much per person we had been spending in the year or so prior to beginning the program. And they very quickly said, it's not enough, we need 100%. And then, oh no, that's not enough, we need more than that. And so it quit being less expensive. It started costing just as much. So the advantage then was, well, at least it's going to give more coordinated care to people, which in fact did not happen for a number of reasons. One thing, they subcontracted healthcare of various types, particularly behavioral health. So somebody would be referred to behavioral health, and if they could find somebody, they would be told, this is how many sessions you're going to have. And no matter what the problem was, and no matter whether they had adequate help in those sessions, that was it. They were cut off from that point on. Same thing for dental care. Very few dentists would accept people in this program, in these programs. The pharmacy, which I'll get into, mainly the inability to get prescriptions filled after they've been prescribed by physicians. One of the basic problems is that in capitated managed care, which is for profit, investments that will result in better care later on are of no value to the MCO. That's money wasted for them because people change plans. So if they do something now that's going to make your health better 3, 4, 5 years from now, make you less likely to be in the ER, less likely to be admitted, and so forth, they don't care about that. They care about their quarterly earnings figures. And so the more money they spend now, the worse it looks for them in the stock market. And these were all publicly traded corporations who were participants. There were 13 different companies at one point. So every dollar spent on healthcare reduces, and so people, because of getting bounced around, felt like pinballs. So a group of, so HAC, a group of healthcare advocates, a coalition of healthcare advocates, decided we need to get rid of this. We need to take it over and make it nonprofit, um, not capitated. And what they did was they filed a class action lawsuit against the Department of Public Health, which many states had done before, that had happened in many states before, but also specifically against one of the companies. And they chose HealthNet because it had the worst record of any of the companies. And so this is HealthNet right here, and then all the other companies pretending that they don't stink just as bad as HealthNet does, but they all kind of stink. Um, they were non-compliant with the terms of the contract. They would deny service without telling the patient. So a patient would say, I need this CAT scan," and nothing would happen. And they'd finally have to call to see why they weren't getting the CAT scan. And um, if they got an answer, it was insufficient. There was no specific reason given. There are federal guidelines which require denials of care, notices of denial of care to be communicated to the patient, and they weren't following this at all. Same thing with pharmacy. Um, it was routine, it was very, very frequent that drugs that were prescribed, the prescriptions weren't filled unless the person could pay out of pocket for reasons I'll also get into. So, um, how did this work? Why did it succeed? Well, first of all, there was a media strategy. Um, and as I said, this was the first ever against the state and a Medicaid managed care company. Um, you know, they're for-profit companies, and if there's anything that corporations hate, it's bad publicity. It puts them back in the horse race to stay neck to neck with everybody else or to be ahead of them, and they're afraid of their profits going down, and so they were very sensitive to what subsequently happened. Um, Other part of media strategy was lots of press releases. We had a lot of different people um, signing letters, writing op-eds, and so forth, and giving interviews. And we really made this part of the public story. People in Connecticut knew that this was going on. This had a high profile. Um, where things really started firming up was in the discovery process. Um, we had lots of anecdotes about denial of service, but we didn't have any data. And so we went to the state and we filed a Freedom of Information Act request. We wanted to know some specific things like how much are these managed care companies paying the dentists and doctors and so forth for their services. It was a black box. Well, the state didn't have that information because they couldn't get it from the healthcare companies. And so we found a Connecticut law that says any company that's doing more than $2.5 million per year of contracted services for the state is also required to respond to FOIA requests. I don't know how many other states have a law like that, but look in your state and see if you have one because this was key to the whole process. So we were able to go to court um, with the MCOs, forcing them to give us information. They lost, we won. They appealed. The Attorney General joined our lawsuit he filed an amicus brief. Um, and we continued with our op-eds. And the governor finally got tired of all this and said, you know what, from now on, all of these new contracts are going to explicitly say in the contract that they have to reply to FOIA requests. So no more lawsuits, no more wasted money or time. Um, that resulted in a bunch of them dropping out. And we finally ended up with three providers. Um, and we did find from that discovery that payment, we found out what they were paying uh, providers, and basically they were supposed to pay them more than the baseline Medicaid rate because it was too low. They weren't. They were paying them the baseline Medicaid rate. Um, they also had ghost panels. Up to 25, 30, 40% of the doctors listed on their website as being providers were not. They maybe had been before, but they were not. So it was very difficult getting an appointment, a first time appointment. Um, so this succeeded, and there was a temporary setback, which I won't go into because I'm going to run out of time here. Um, but the governor made a deal to let them continue as before, except with the FOIAs, um, in exchange for them being willing to fund a low-income healthcare plan for people who didn't qualify for Medicaid. So in the end, there were three companies left, and two were for-profit companies. One was Community Health Network, which was a nonprofit, and I was named to their quality improvement board. So I saw firsthand that Community Health Network, unlike the others, really was concerned with coordinating care, with quality of care, with getting helping people to get good health care. Um, and so that was the landscape for that time. Um, so we had uh, we had an audit because it's a federal requirement that MCOs, all three of them, have to have audits. And so when they did, we felt that the audits were not adequate. And so we got the controller to order an independent audit and determined that there was $50 million in overpayment was the result of that audit. And that went back to this deal for the non-Medicaid program. That was what sweetened the pie. So what was another thing we did? So we did a secret shopper. There was a pediatrician group that was able to generate fake Medicaid IDs. The state cooperated with this, and they started calling participating providers. And what they found was that only 25% of people were able to get an appointment. 75% of the people who had this Medicaid, this managed Medicaid, were not able to get one. And the reasons they were given was, I don't participate, I never participated, I don't accept your plan, etc. And so again, we're writing letters, we're in the news. This was an ongoing thing. Same thing with prescriptions. Um, they were the two for-profit companies were refusing to pay for prescriptions, um, even though they were on the list of approved drugs by Medicaid. Um, they were saying, well, they're not on our formulary, and so we're not going to cover them. And technically, that's fraud. So at this time, by now it's almost 2010. It's 2010, and we have a new governor, Daniel Malloy. And when he was elected but hadn't taken office yet, he set up committees on specific areas and asked them to look at different specific problems specific to their areas and to come up with policy papers. And so we got involved in the healthcare committee and made this a major issue so that when he took office, um, he was all ready to go with the program that we have now. So we replaced the MCOs with um, an ASO, Administrative Services Only, which turned out to be Community Health Network because they had actually done a good job. They were the one that did a good job. Um, we found that there were programs already like this in 2 other states, and instead of paying an insurance company, basically, there was extra pay for primary care providers to do the work of managing care, coordinating care, uh, and this was based on the patient home model. Um, so we started that and called it Husky Medicaid. It's been going on for 17 years. It has transparency. You can Google Connecticut Husky Performance Dashboard, and it'll show you all kinds of information about enrollment rates, enrollment stability, um, average wait time when you call them, um, things that are important to people who rely on these services. Um, we've looked at a bunch of benchmarks for the current system. We improved early diagnosis of childhood cancers. We have very high vaccination rates, 20% higher than under the old system. Access to care is much better. At the time we started, we were the ninth highest cost Medicaid program in the country. This brought us down to the 22nd highest cost Medicaid program. And we have a medical loss ratio of 97%. That's almost Medicare range. I mean, that is Medicare range. Under the old system with the private MCOs, their medical loss ratio was around 80%, and one company had an MLR of 60%. They were keeping 40 cents on the dollar that they collected. Um, why did this work? First of all, we're a small state, and that helps. Um, I know Dick Blumenthal. I know Chris Murphy. I know Rosa DeLauro. Um, I, I'm sure I wouldn't know both of my senators if I were in Illinois or New York or a much bigger state. So that helps. Um, we had and still have a very active advocacy coalition, which is not just medical professionals, but some very good attorneys, public interest attorneys, social workers, and we had the right elected officials. Not every governor, like Dan Malloy, would have done what he did, and without what he did, we wouldn't have our system. There were a lot of pieces in the puzzle that fell into place. Um, Having good research, having data, anecdotes are what move people's emotions, and data is what moves the bean counters. And you have to do both. Um, Use of media, and and that's it. This picture. So I'm very active in PNHP. We had our a day of action um, in October. Uh, we have a campaign against Medicare Advantage, and so the action that I chose to do in Connecticut was to organize a press conference at the state capitol. Um, Senator Blumenthal's subcommittee in the Senate um, was just completing their study of Medicare Advantage excesses and problems, and they came out with a scathing report about a month later. So this all tied together, um, and the fly in the ointment, so to speak. Um, you always have to remain vigilant because uh, for-profit companies, they are always stalking you. They're always waiting for the right moment. And the right moment for them was the fact that we now have a governor um, whose income last year from his stock profits was $52 million. And his wife, who is a health industry venture capitalist and who's worth $650 million, decided that, everybody else is doing for-profit managed care. Maybe we should go back to that system. And luckily, we had a whistleblower um, on the inside who got wind of this, told us about it, and we preemptively started campaigning against the very idea. So as a compromise, he said, okay, we'll do a study. And so he hired a legal firm who represents Anthem, Blue Cross, Aetna, to do this study. And we reacted to that. So they added Accenture to the mix. They did a study, and what they found was the report highlights that the current operations of Connecticut's Medicaid program stand out as a model of cost efficiency. So that pretty much has blown that idea out of the water. We don't think it's going to happen, but again, we're staying vigilant because you never know. Um, so, what is in the works? In our current legislative session, which just started last week, um, there is a bill to limit private equity involvement in hospital ownership, lab ownership, rehab services ownership. There's a drug rehab facility in New Haven that last year, owned by a private equity company, and last year, literally in one day, told all of the employees that they were fired and all of the patients that they had to leave and find care elsewhere in one day, no warning, because they went broke. They were losing money. Um, so that incident is going to, almost certainly result in legislation that's going to strictly reduce the ability of private equity companies to come in and strip hospitals of their resources. We're dealing with that in another issue. There's 3 hospitals that were bought by Prospect, um, which then sold the land that the hospitals are on to their own shell companies. So the hospitals had to start leasing the buildings, and they did all sorts of things to strip money out of the hospital, and now they're bankrupt. And we're trying to figure out how to keep them open. Um, Another bill, which I'm not sure if it'll pass or not, but it's not a bad idea, is to require that all medical groups and ambulatory surgical centers be owned by physicians who are actually working there, and not by somebody on Wall Street. So that was about 15 or 20 minutes, right?
Excellent, excellent. Thank you, Phil. Yeah, it gives us
So,
hope.
yeah, no, I mean, well, this is a bad time now because we have no idea what's going to happen with this new administration. I've read Project 2025 because I started a work group to look at it, and um, there's going to be cuts. There's going to be huge cuts in things. It's going to be tough, but that's all the more reason to try to. I mean, maybe you can't get money for things, but if you can at least keep private equity out of the picture, if you can get laws passed with those restrictions, uh, that's a big help. That's a big help.
Great. So could you take your slide down and we'll open this up for
Yeah.
discussion? And then just to remind everybody, please make your comments as concise as possible. Don't speak over somebody else. Use the raised hand electronically so we can see that you're in the queue. And then follow the WAIT reminder. Why am I talking? Um, and put notes in the chat for us. Avoid anything accusatory, demeaning. And then if anybody breaks the norms, they have to do a penance at the end. And usually that means singing a song of some kind. So let's open this up for questions. Let's see who's first. Hey, Aruna.
Can you please explain what is AOS?
You mean ASO?
Oh, ASO, okay.
Yeah, that's administrative services only. So the state doesn't run the state Medicaid program. They hired a company, which Community Health Network, they hired a company to administer it, but that's all they do. They don't collect any money. They have nothing to do with the payments, except just to make sure that people are getting paid. But they get paid on a contractual basis, a set amount per year. And so there's no incentive for them to try to shave money out of the system. So it's
But
administrative services only.
so that one company that you found, MCO, that your nonprofit MCO that you found was genuinely interested in giving the care. In,
Yes.
and that is a hard commodity to find amongst MCO.
Yeah. Well, you know, they were nonprofit. That helped. They were not they didn't have a profit motive.
Next is David Sonnenbard.
Yes, Dr. Phil, do you have do you have advice or guidelines uh, for affecting this work in populous states like California?
Well, you have to do the same thing, but it's more difficult, I think, just because of the numbers. Um, how do you I don't know if you can think of an issue where there's been a grassroots campaign. Um, but it does require ongoing advocacy groups. They have to be well organized, and we're very lucky. There's three or four, well, there's four individuals that I can think of in Connecticut who just year after year, they're always at it. They're very good. They're very intelligent, organized, and committed. And everybody coalesces around them. So you have to start there, I think.
Hank from Maine.
Sure, thank you. I have a list of questions in the chat, and basically, Mike, ask Phil who was organizations or who was the lawyer that led out in your effort, and I'd like to have their lecture to us next on the nitty-gritty process the of how the legal work was done, and basically is how much did it cost? Who did you run it through, your C3 or your C4, or was there a separate entity that ran? Was there a pro bono, low-cost legal firm, et cetera, et cetera? Kind of like for me to go to certain advocacy groups in Maine, let's say, and to lay out a process, I think they'd want to understand it better. And I'm wondering if Phil can recommend to Mike who that next speaker should be from Connecticut.
Well, I think he's already spoken, from what I understand. His name is Sheldon Tubman. and he is a disability rights lawyer. That's his main thing. But he spends a lot of time, a lot of unpaid time as a health advocate. Um, so that's who he is.
So that was the point person sort of.
Yeah.
And did you again? How much an estimate of costs, and who did you run through your C3 or your C4, and how many years did it take to do that?
I couldn't answer that.
How about length of time?
Sheldon would know. Yeah.
Next up, Rose.
Hey, everybody. Thank you so much for this. Just thank you, Connecticut, for doing this. I got to tell you, we're working on this very thing here in Minnesota. We are scheduled to get a plan from our Department of Human Services in 2026 to be able to move to direct provider payment system here in Minnesota, similar to what you did in Connecticut. And I just, I don't know that I have a specific question. I've met Sheldon. We've actually had Sheldon meet with some of our key legislators here in Minnesota, and he's just full of information. So for whatever that is worth, Hank, you should definitely reach out to Sheldon. I just want to say, I really do believe that the, deprivatizing our public health programs in this country at the state level is job one for all of us. We have got to start to build the public infrastructure to create the conditions to make single payer happen, whether that's at a state level, preferably at the federal, but we all know where the federal's at right now. So the states may be the incubators at the moment. So beginning to build that internally is to get these privatizers out of our public health programs first, and then figure out how you expand it from there. I'm just convinced this is the best sort of incremental in a positive way that we can start building towards what the gold star is for all of us, which is to get, a publicly funded, privately delivered healthcare system. Thanks.
Amen.
Any other question? Oh, David.
Yeah, I just wondered. I read an article from your Connecticut Mirror the other day that said there was some segment that was actually costing more under your present system, and I can't remember the details. I think it was some of the most chronically ill people. Does that ring a bell? And can you elaborate on that?
Yeah. Well, that was part of the study. I can't go back to the slide. I'm not going to screen share it again, but I'll read the rest of the sorry. I'll read the rest of the quote. I started with the report highlights. This is from that study that the governor commissioned. And I think they put this in to keep a foot in the door over the possibility of making the transition, which is why I say, eternal vigilance. So Medicaid program stands out as a model of cost efficiency. That being said, it does highlight some areas where we can make further improvements, particularly when it comes to individuals who have chronic conditions and those with complex needs. And of course, that's very difficult to manage, people with complex needs. And we admit there's always room for improvement. And the best chance of getting that improvement is to continue with the system we have and to work on it. It's not to go back to a system that has been proven to give lower quality care and at greater expense. That's for sure.
Well, thanks. We have time for two more questions, and then Chuck's going to tell us what he's been doing in Washington, D.C. to empower the states, producing their own universal healthcare systems. Paul, and then Ellen.
Hi, I'm Paul. I'm a nurse in Connecticut. So I'm really proud of all the work that you've done, Phil. My question is, besides going to the media, on your last, years ago when you were doing that whole campaign, how are you building a movement? I guess, like, how are you disseminating information to help build a movement to support this work? Like, are you utilizing website or social media, or I guess, what are your recommendations for reaching people?
Well, the answer to that is you have to decide who do you want to reach. And in this particular kind of thing, social media gives you sort of a background thing, but the people you really want to reach are the people who read the Connecticut Mirror, Connecticut, was it Political Junkie, these papers that all the legislators read, all of the administrators read, and so forth. That's really where you get the message across. You want to reach the deciders, the people who are going to move in the direction that you're hoping that they'll move in. In our particular type of issues that are going to be decided in Hartford, it's very important to make sure we're reaching the legislators, the regulators, the staffers, and helping to form their opinions or influence their opinions and their actions. And it does help to have grassroots, the occasional demonstration, trying to inform people on social media. One thing that we found out way back in the beginning, it was actually very difficult to get much movement from the patients that we were trying to get good health care for. So we did that as much as we could. But what really worked was getting data and using that data along with anecdotes for the emotional side of things, but basically data to thinkers and regulators and people who are going to make decisions and write laws and stuff, and get it out there enough in the public that somebody might say, "Hey, I read this," like you just said, or somebody, "I just read this article and it said this. What do you say about that?" So TV coverage, not so much. TV coverage means like a 5-second soundbite. The Connecticut Mirror and those papers are very important.
Thanks, Phil. Ellen, you had your hand up a minute ago.
Yeah, actually, that was an excellent answer. I was going to piggyback on Paul about building the movement, and I appreciate everything you've said and about reaching deciders. It sounds like you had a very cohesive coalition led by some very strong leaders. Did you have any kind of division within your movement, or was it pretty much solid and everybody coalescing, as you said, around one?
No, it was solid. I think for one reason, and you may have noticed that I called it HAC, Health Advocates Coalition. It's never been a really formal thing with a president and a treasurer and all that. And that kind of avoids any, power struggles, or we're just all a bunch of people with the same tendencies, the same goals working together. And I think that's been a big part of it as well.
Oh,
Thank you.
thanks, Phil, and you're welcome to stay on, Phil. While we hear
Just one other group I didn't mention. there's a group called CCAG, Connecticut Citizens Action Group, and they work on a bunch of different public interest policies, not just healthcare. And they are kind of the glue that does help hold things together. I don't think I've ever actually looked at their website, but I'm sure they have one. It's probably worth looking at. Liz Deal is their executive, and she's just tremendous. So we're lucky to have people like that.
Great. Thanks, Phil. Thanks so much. This has been so informative and very pertinent to us here in Oregon as well as we try to control, as you may have noticed, Optum gobbling up large clinics, and we're just doing our best to create legislation to prevent that. So
there's an article in today's paper that Optum has lost 4 million customers.
we wish we were some of those. Thanks, Phil, and you're welcome to
Okay.
stay on. But I realize you may have somebody in the emergency room waiting for you. So, Chuck, it's yours.
Okay. All right. Thanks. And Phil, thank you for your excellent presentation and the work that you're doing. I did actually drop a question in the chat. I didn't want to jump up, but have you looked at Ed Markey's Health Over Wealth Act, which is also designed from a congressional perspective to go after this problem of predatory equity firms? Steward Health in Massachusetts has gotten a lot of attention. Have you seen that, or are you endorsing
Yeah,
that?
I have. Unfortunately, as we alluded to before, at the national level, it's hard to imagine anything like that passing.
Sure.
At this point in time, it's really up to what people do in the various states,
Right.
unfortunately, but that's, I
Yeah.
think, the
No,
reality.
100%. I mean, but nonetheless, it's an education tool. It's an instrument. I mean, similar to the National Medicare for All bill, which we're not going to see pass anytime real
Right.
soon. But the reality is that we need it out there for organizing and educating. So thank you, Phil.
Okay.
So I did put in the chat just a very quick summary of what I'm doing with Representative Khanna on the House side, and also Senator Markey, who's carrying the companion bill in the U.S. Senate. For the first time, we have a companion bill to what's the State-Based Universal Health Care Act. I want to assume everybody is familiar with SABUCA, what we call it, and actually we want to change the name of the bill for reasons that I'll explain to you. But basically, this is legislation designed to get Congress enabling the states to capture, bring back to the states the federal healthcare dollars with guardrails. Because a lot of people come at the bill and they say, well, what's going to keep the states from block granting or misusing these funds? Well, the legislation is very specific in making sure that the federal dollars, and we're talking about Medicare, Medicaid, children's health, federal employees, TRICARE, et cetera, that those dollars, when brought back to the states, will allow individual states that have already put legislation into effect to create a highly efficient, a far more efficient funding mechanism, right? Very, 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 very close to a pure single payer, or what I call one payer. And why do I say, our organization's called One Payer? And you might be surprised, but when I have the conversation on Capitol Hill and I talk to people and I say, well, what group are you with? I'm with One Payer States. Huh, that's interesting. No one has said, oh, is one payer the same thing as single payer? But the reality is that it is. But nonetheless, the conversation always goes forward without triggering people. And I'll make a reference to what let's see, Mike, do I just copy out of the chat? Can people see that on the screen, the chat?
No, I'll see if I can work that out.
That's okay. I'm going to work off of that. And if people can hold off on dropping things in the chat, because it's going to bump my notes. So just hold off, if you will, for a couple of minutes. I just want, this is inside baseball. This is not really for wide distribution, but I want you all to know the work that we're doing and that I'm doing specifically to move the dial, to move the conversation, to move the effect of our legislation. I'm targeting Republicans, and I'm not even aware of any other single payer lobbyist in Washington, D.C., who's ever done this or taken this approach. And it's based on successes that I had between the years 2000 and 2010 in Pennsylvania, where we were able to get numerous single payer hearings from Republican chaired committees, caucus hearings, and then a standing committee hearing. And the reason that I was able to, we were able to do that is what I call radical persistence and targeting our audience using language and frames, focusing on the economics of healthcare. We were way ahead of this. One payer states was originated between three states, Pennsylvania, Maryland, and California, all of whom wanted to do an economic impact study on our own single payer bills. That's our origin. That's our origin story, 2009, 2010. So what I've asked Ro Khanna to do is to reintroduce what we're calling the SABUCA bill, State-Based Universal Health Care Act, this year as early as possible. We would love him to do it this February. I finally heard from him 3 hours ago after knocking on his door persistently since, I mean, I've been at this work since September of 2023. And then in conversation with our work group working on this issue, have come to the realization that if we don't switch up our strategy, we're going nowhere. So we want him to introduce it as early as possible so we can get working on it fast, early, before members settle in, and especially new members, newly elected members, both Democrats, but especially Republicans from swing states. And you might be surprised how open they are to that conversation. In fact, they are. And so the second point that I'm emphasizing with him is that I've been working very hard at connecting with my former representative, Brian Fitzpatrick from Bucks County, swing district, Republican on Ways and Means. Brian Fitzpatrick, finally, after numerous approaches, has said, yeah, this bill does make a lot of sense. Let me talk to Ro about possibly co-introducing the bill together, right? Co-introducing. And so this is happening. We're working on getting this to happen in the House so that Khanna will co-introduce it with Brian Fitzpatrick. I'm not saying it's a done deal. This is what I'm working at. The third thing that I'm asking Khanna to do is to drop specific prescriptive language in the bill that simply trips us up. There's no point in putting prescriptive language in the bill defining what exactly healthcare is. At this point in time, we need to get the bill passed. And the bill is most likely to aid progressive states such as Oregon and Washington and California, Minnesota, New York, Maine, and a few others that already have defined healthcare much more broadly without getting into a lot of the detail. The point of the legislation is that it's enabling and not prescriptive. So I've asked him to drop the prescriptive language in the bill that's only antagonistic and is only going to keep Republicans from signing on. So that's number two, right? Number one, introduce it early. Number two, co-introduce it with a Republican. Number three, introduce it with language stripped out that's prescriptive in terms of defining what exactly healthcare is. Number four, coordinate early introduction also with Senator Markey, who I mentioned with the Health Over Wealth Act. Markey is running the companion bill, and we want Markey to do the exact same thing on the Senate side, which is to work with Phil, with your U.S. Senator, potentially Susan Collins, or Elisa Murkowski of Alaska, to do exactly the same thing, to co-introduce it in that chamber, in this case, the upper chamber of the Senate, to do exactly what we're asking Khanna to do in the lower chamber in the House, which is to co-introduce it with a Republican so it's got push from both sides of the aisle. It's got buy-in from both sides of the aisle. And in addition, I'll just tell you that specifically, I'm working on the Pennsylvania delegation. Two new members who were just elected, Representative McKenzie and Representative Brosnahan, who are very open to this conversation. And it's important, again, to have these early conversations with healthcare LAs before the Congress gets started and before members are told you can do this and you can't do that. We want them to jump on it before they're being told by leadership what they can and can't do. So that's number four, again, coordinating and getting Republicans involved, signed on, co-introducing. And number five is rename the bill. And I would love people in the the healthcare justice movement, single payer, Medicare for all, to really be smart about this. And I know Rose was in on this meeting, as were a number of other social or healthcare justice leaders. We had a briefing on the findings of the Medicare for All Political Action Committee survey back in September in swing states. And one of the major takeaways was, what framing works most effectively? What is it that seems to resonate with people the most in terms of getting their buy-in, or at least keeping an open mind as to what a universal healthcare system, guaranteed, comprehensive, cradle to grave, patient-centered healthcare system, what that actually looks like? And the reality is that that survey indicates that people are, again, like I said earlier, triggered when you use terms like single payer. That's the worst thing you can call it on Capitol Hill. 3/4 of the members will dive under the desk and avoid the conversation. Secondly, Medicare for All is perceived as a Democratic partisan frame for universal health care. So that doesn't work particularly well either. And that's Permilla's own survey that indicated that universal health care and healthcare for all have a slightly better resonance across the political spectrum. But I'm going back to my days when we were very effective in Pennsylvania, what I mentioned at the very top, and that is to use language such as Family and Business Health Security Act. I'm using that as an example because that's what we used in Pennsylvania, and that was the language that we were able to use, the framing we were able to use to get numerous Republican-chaired hearings, caucus hearings, standing committee hearings. And why is it that I have to say that we've got to be smart about this. We've got to call out our friends and say, why do we use language that is only going to block ourselves from making progress? Let's call it something that is much more innocuous and speaks actually to what it is that people need. They need health care for their families, for their businesses, for their communities, they want a healthcare system that is going to provide security. And why not use that language, that depoliticized language, that is going to be far more effective, that is going to be much more resonant across the political spectrum. So this is the work that we're doing, and this is the work we need support on. And this is the work that no one else, as far as I know, is doing. We invite others to jump in and to join us. And we're going to be launching another petition in support of the legislation. Again, hopefully we will rename it, get it reintroduced in February, ideally, and then push forward with as much Republican as well as Democratic Party support, so that we can actually get this bill passed to support universal health care bills that are being passed at the state level. So I'll stop there, see if folks have any questions, any feedback. This is a process I've been working on for years and years, but it's time tested, it's focus group tested. It's been tested in meetings, one-on-one meetings, away from the Kliegel lights, away from the media, and members and their staff are very positive about this legislative approach when it's done in a way that's very depoliticized. So I'll stop, see if folks have questions, comments. I mean, give me a thumbs up. Is it what this approach of making, does it make sense to you all? Does it make sense in terms of how we need to move forward in getting our legislation passed?
Aruna has her hand up.
Hey, Aruna, welcome.
Thank you. Thank you very much for informative information on this approach. My worry is if the language is not very clear when it comes to implementation of the law, things get lost. That is the piece that I'm worried about. Your approach really makes sense, but politicians try to keep the laws very ambiguous, and then the implementation, and then there are lawsuits and other things. What are your thoughts?
Oh, yeah, the policy prescription is exactly the same. This is really a question of really good wine, but putting it in a different bottle. I mean, the point is branding. And if we haven't learned anything, from Frank Luntz and the Republicans, then shame on us, because they kick our ass all over the place because they're so much better at framing and repetition and using language that really does connect to people. And that's the framing. So the framing and the branding is one thing. So Aruna, I'm telling you, we're not running away in any way from the actual prescription. The point is that our legislation is fundamentally designed to get a robust single payer system at the state level, the best possible push and assist going forward. And this meeting is recorded, but it's important that you all understand that this is the game I have to play on Capitol Hill, and I'm pretty well practiced at it, having succeeded considerably, in a very conservative state like Pennsylvania. So just know that the bill has guardrails. The bill has very specific targets for achieving universal health care coverage for its citizens. The bill also does need to go through Health and Human Services Secretary. And that is a concern right now, of course, with Bobby Kennedy potentially, and his nomination is not 100%, but nonetheless, we are going to have to work with the sitting HHS secretary as this legislation goes forward at the state level, as the states submit applications to the Health and Human Services Secretary to acquire those federal healthcare dollars, as well as, and we strongly believe it here at One Pair States. Not everyone does, but we also want an ERISA waiver. That language is also very specific in the bill itself, right? The Employee Retirement Income Security Act, which would require businesses, self-insuring businesses, to participate in a way that makes it that makes the state-based effort, the state-based single payer plan, that much more robust. So this language is the policy language isn't changing at all. It's how we frame it. It's how we talk about it. It's how we have the conversation. And you should know also that Mike and others we've created these one-page talking points that are designed to appeal to members who are on board with the Medicare for All bill, Democrats who only want to see expansion of the ACA, more moderate Republicans who are inclined to support state innovation, and those who are simply needing to develop good faith with their constituents, especially in these swing districts. So what we've done is we tailor our message in a way that promotes the bill without changing the bill itself, right? So the game here is politics and policy combined. Mike, and then Bill.
Yeah, how should we be talking with our federal delegations now? Do we mention the previous number of the bill? What do we want them to do?
Yeah, so contacting for your House members, contacting Rep. Khanna's office and the representatives, Healthcare LA. Her name is Preeti. I'll put her email address. This is the legislative aide to Ro Khanna, Preeti. So again, that's Rep. Khanna's Healthcare LA. So when you contact your office, and I would go directly to the healthcare legislative aid for your member. Just go straight to DC. So many times when you try to go through the district office, the message never gets through. So contact directly, and the phone number in DC is 202-225-3121. There's a 224-3121, I think 224-3121, right? So I'll put that in there too. So this is the direct Capitol Hill number. A lot of you know it already. It's the same number I had when I was Alan Cranston's healthcare or his personal aide back in 1982. Same phone number, Capitol Hill switchboard. Go directly to get to get to the Healthcare LA in your House member's office, as well as your senator. And the Senate contact for Markey is Tara Wilson, and Tara is at TARA_. So I don't want you to contact directly these people. I want your healthcare LAs to contact Preeti and Tara. It's Tara Wilson at markey.senate.gov. So when you contact your two U.S. senators, have them contact Tara Wilson. And the message is, we support the new, they'll know what you mean by this, that we support the new strategic approach to get this legislation, previously numbered HR 6270. The bill number is going to change, right? That's the House Bill HR 6270 and S 4817. That's the Senate companion bill. So they'll know that the bill needs to be reintroduced, but that's a reference to what was called the State-Based Universal Health Care Act. Does that help, Mike?
That helps a lot. And just as a request to everybody that's listening, who would you like to hear from next? Shall we have Phil back again? Shall we have Henry Broska to tell us how did Canada transition from a sort of situation like we have to what they did took them 10 years. But we're looking for speakers to continue this wonderful conversation we've had today. Well, we're what? 9 minutes past the hour.
I put my email in, so I'm happy to coordinate inside outside lobbying. So you let me know that your members Healthcare LA is primed, and I will happily go over to them. And I'm especially keen at this point on getting to Republicans, but Democrats as well. I think it's fair to say that we cannot rely. It's more than fair. It's proven. We cannot rely on the Democratic Party to get this done. It's up to us, and we have to be creative in how we go about this work. And also, please do support the work that we're doing. If you don't know, I'm a volunteer doing this work, getting my expenses paid. I might be actually paid at some point in the future. I know that my skill set could command a lot of money in the private sector, even the nonprofit sector. I don't really care, except that I just want you to know that every dollar that you contribute to One Payer States goes really, really, really far. So please consider $50, $100, or monthly contributions of $5, $10, $20, $25, whatever you can handle. It really, really, really is important. And this is innovative, strategic work that we're doing. And so grateful to our partners in this work, including Rose Roach, Diljit Singh, who's the new president of PNHP. I've had conversations with her. Grateful that Phil is here with us today. Again, Labor for Single Payer, all of our partners at the state level, Public Citizen, Social Security Works. Just know that we're partnering up as much as possible with folks, but that we're leading the charge in terms of taking new, proven strategic steps to advance this legislation, get states adopting and modeling, similar to the way that Canada went forward through a modeling of universal health care, single payer in a single province, that being Saskatchewan back in the 1960s. Thank you
Thanks,
again.
Chuck. Yeah, one
Yep.
more question, Aruna, and please get real close to your microphone so we can hear you.
Hey, Aruna.
Hello. Thank you for all the guidance. Wanted to know, should we wait till the bill is introduced by Congressman Rokana or call before the bill is introduced by either senator or the congressperson?
Yeah, let them know now. Call them today. Honestly, just say that, look, we've been briefed on the new strategic plan coming from One Payer States. We heard a brief talk with Chuck Pinocchio. They know me. And I've put in front of them, what it is that needs to happen strategically. And I went over that with you all today. So we're all on the same page here. What we need Kana to do, what we need Markey to do, is to take this seriously and introduce this bill very early, again, before the sort of deeper set cynicism sets in among a lot of these healthcare aides. Right now, when I'm talking to a lot of the Democratic legislative aides, their response to me is, well, we're out of power. We're not going to be able to do anything for the next 2 years. And my response to them is not specifically BS, but it is BS. And we're not going to take that. We're not going to roll over and just say, well, there's nothing we can do for 2 years. I mean, obviously, the work that our partners are doing in terms of fighting privatization, and we're in that fight as well. That's critically important work. But how do we move forward? How do we get to the gold star? How do we get to the North Star of expanded and improved Medicare for all? How do we do that? I believe, as a theoretician, as a political scientist, as an historian, as somebody who's been doing this work for over 50 years, that the states are the much more likely pathway to go, especially given our political dysfunctionality, and the fact that we're going into very dangerous times. I think out of opportunity comes, out of crisis comes opportunity, and we need to take this crisis moment to pounce on it and take advantage of really a very soft environment that's open to persuasion.
Thanks, Chuck. And thanks everybody for attending. And thanks specifically to Phil for your erudite and inspiring story about what's going on in Connecticut.